I welcome all of you for this session. I'm sure most of you are already masters in managing acute coronary syndrome, but keeping with our theme for this year towards excellence, setting clinical standards in medicine, I want to re-emphasize the important steps in managing acute coronary syndrome. So as one nation, we will be adhering to one clinical standards. We'll start with a case scenario, a very common case we see in our day-to-day life. A 45-year-old man coming to the emergency treatment unit with central chest tightness for 4 hours duration, associated with jaw tightness and sweating. He has background of hypertension. He is also a heavy smoker. His examination is normal, including good volume, regular pulse, blood pressure normal on both arms, normal auscultation of the heart and lung bases. So this patient gives a history of a cardiac chest pain. We broadly classify the chest pains as cardiac, likely cardiac, or unlikely cardiac. In the past, we used to say atypical chest pains, but currently we say unlikely cardiac if that chest pain points towards a different clinical diagnosis. So this patient clearly gives a cardiac chest pain. So what's the management for this patient? We'll start with the initial management. The first step is getting an ECG. So we should aim to get an ECG within 10 minutes of first medical contact, the first time the patient tells chest pain to a doctor or the triage nurse. So it's important that we look into the things where we have the ECGs been taken on time, or what were the reasons for the delays, and try to make sure we achieve this target of an ECG within 10 minutes of the first medical contact. Everyone who has a cardiac chest pain, who is suspected to have acute coronary syndrome, should be on a cardiac monitor, and make sure you know where the closest defibrillator is. So they should be wired up to the machine. And if there's a arrhythmia, because this is a situation where people can get a malignant arrhythmia and which can be treated and a life can be saved. So make sure everyone with a cardiac chest pain is on a cardiac monitor and you know where the defibrillator is. Oxygen is not normally given unless there's low oxygen saturation. So current ESC guidelines suggest to give oxygen only if the saturation is less than 90. Another important thing in managing acute coronary syndrome is pain relief. If the patient is in a lot of pain, that invariably increases the heart rate, increases the myocardial oxygen demand, and worsens the outcome. So it's very important that we treat the pain. For mild to moderate pain, we can give GTN sublingual up to 3 times. Make sure patient is lying on a bed or seated and not standing when you give the GTN. We should avoid GTN if there's hypotension or marked arrhythmias. If we suspect right ventricular infarct, then we should not give GTN because that can cause hypotension. In severe known aortic stenosis, don't give GTN. And if the patient has been on a phosphodiesterase inhibitor like sildenafil in the last 1 or 2 days, don't give GTN. In that case, and of course in patients with severe pain, we treat with IV morphine. Morphine has an added advantage of reducing the myocardial oxygen consumption and has a better outcome. We can combine with an antiemetic to prevent patient getting nausea and vomiting. Once these initial measurements are done, the next important step in managing acute coronary syndrome is to decide whether it's a ST elevation MI or whether this is non-ST elevation acute coronary syndrome. As you know, this is done by the ECG. I'm not going to go into detail about interpreting ECGs during this limited time, but an ST elevation is more than 1 millimeter ST elevations in at least 2 consecutive leads, except V2 and V3, which has different thresholds. So normally it's 1 millimeter. In females in V2, V3, we go up by 0.5. So it's 1.5 millimeters. And if it's a male who is more than 40 years, it's another 0.5 higher. So it's 2 millimeters. And if it's a male who's less than 40 years, we go up by another 0.5. It's 2.5 millimeters. Keep in mind about the STEMI equivalence as well. So posterior STEMI, you won't get it unless you do the posterior leads, and AVR, ST elevations, and left bundle branch block, which are all STEMI equivalents. So needs to be treated like ST elevations. Once we decide this is ST elevation or not, we'll now go down the ST elevation myocardial infarction route. Step 2 is to decide what's the time between first medical contact and time for a PCI. So it will be a standard time for your hospital, your unit, depending on the time of the day. So if you think it's less than 120 minutes, then it's beneficial to transfer the patient for primary PCI, and the cardiologist will take over the care. But if it is more than 120 minutes, which is most likely the case for a lot of us, in that case we need to go for medical thrombolysis, because transfer for PCI will be too much of a delay, and when we lose a lot of vital muscle mass from the heart. So let's go down the more than 120 minute route for now and go for medical thrombolysis. So in that scenario, the next step is giving the loading doses. So step 3, loading doses. I'm sure you all know about this very well. So first step is giving aspirin 300 milligram. Just I want to highlight this fact that what we have in the hospital is gastro-resistant aspirin, which is, if just given with fluid and swallowed, it will not have an immediate action. So make sure you tell the nurse that it's either should be crushed and given with water, or patient need to chew it and swallow it. So make sure that's done, otherwise the benefit of aspirin will be lost. We give clopidogrel 300 milligrams, but if the patient is more than 75 years, there's a risk of intracranial hemorrhage, so we give only 75. So regarding clopidogrel, what you need to remember is if less than 75, 300, more than 75, it's 75 milligrams. If you have prasugrel or ticagrelol, they are superior to clopidogrel, but don't give if they are more than 75 years. Then we give atorvastatin 80 milligram as stat dose. Step 4, giving enoxaparin. We start by giving a 30 milligram bolus intravenously as soon as possible, and then follow it up with a subcut 1 milligram per kg dose, and this should start after 15 minutes from the IV bolus. This can be continued until the hospital discharge, or maximum 8 days. The thing to remember is the first 2 doses, the total dose should be less than 100 milligrams. That means the first dose of subcut enoxaparin should be maximum 70 milligrams. Again, a patient who is more than 75 years, no IV bolus due to risk of bleeding, and we give the first dose as 0.75 milligram per kg. In patients with renal failure, less than 30 creatinine clearance, we give the same dose, but give it every 24 hours. So the same dose, no reduction, but giving it less frequently in renal failure. Step 5, thrombolysis. So we can give medical thrombolysis within 12 hours of onset of chest pain for patients with persistent ST elevations. And also within 24 hours, we can still give it if there's evidence of ongoing chest pain, ongoing ischemia, like chest pain or dynamic ST elevations. Check the contraindication, which I'm going to come back later, and then start within 10 minutes of the diagnosis. So that should be the aim. So again, try to see what delays this giving tenecteplase within 10 minutes and try to correct them. So what we should achieve is within 20 minutes of first medical care, we diagnose ST elevation MI and treat it. This is because time is muscle, and every minute you delay, patient might end up losing valuable cardiac muscle. So tenecteplase dose you can give according to the weight, and important thing again, for more than 75 years, we give half the dose due to risk of bleeding. If we don't have tenecteplase, we can still give streptokinase, but I think currently we do have tenecteplase, so that should be the standard of care. So the contraindications, we have a big list of absolute contraindications. And again, there are another big list of relative contraindications. It's impossible to memorize all these, so don't try to memorize and try to do it by heart. Have a checklist printed in your unit, in the ETU, and go through that with the patient so that you won't miss anything. After tenecteplase, the final step in the management of ST elevation MI is to assess for reperfusion. So relief of symptoms, improving the ST elevation more than 50% at 60 to 90 minutes interval, restoration of hemodynamic instability or restoration of electrical stability. Those are the things we are guided by. And if there's evidence of failed thrombolysis, contact the nearest PCI center and transfer the patient for a rescue PCI. Quick word on non-ST elevation acute coronary syndromes. So they can be either unstable angina or non-STEMI depending on the troponin result, but management is likely the same. Give oxygen, pain relief, aspirin, clopidogrel, and statin. Again, aspirin chewed or crushed, and clopidogrel only 75 if more than 75 years. Start with enoxaparin for non-ST elevation ACS, 1 milligram per kg every 12 hours. Minimum we give for 48 hours in our unstable angina patients who have a negative troponin, and otherwise we can give until hospital discharge or maximum 8 days. Again, renal failure less than 30 creatinine clearance, we give dose, the same dose, but once a day. Every patient with acute coronary syndrome, we start them on further medications to improve symptoms and also for prognosis, improve prognosis. Beta blockers should be started on all patients within 24 hours if they are hemodynamically stable and there are no contraindications. AC inhibitors, again, to start within 24 to 48 hours. And if they develop a dry cough, we can later change to ARBs. Everyone should be on dual antiplatelet, aspirin and clopidogrel for at least 1 year. And after that, make sure we stop one of them, because if we continue both after 1 year, there's risk of bleeding. So it's preferred to continue aspirin, but if there's any intolerance, the new guidelines always says you can continue clopidogrel for lifelong. The statin dose should be continued, a high dose statin, 40 to 80 milligrams, and LDL target should be less than 55 for a patient who had a acute coronary syndrome. If their LDL at the beginning was 55 to 100, then we should aim to half that. We can recheck the lipid profile in 4 to 6 weeks, and if we have not achieved the target with maximum tolerated statin dose, we start ezetimibe as well. If 2 episodes of ACS within 1 year, LDL target will be less than 40. There's a place for low-dose colchicine in patients who have poorly controlled risk factors or who has recurrent ACS, but it will be a specialist decision. Patients on dual antiplatelets should be on a PPI, but avoid omeprazole or esomeprazole because there's an interaction with clopidogrel. So that's the basic management steps in managing acute coronary syndromes.